Good afternoon, ladies and gentlemen. Mr. Chairman, thank you for the opportunity to present this piece of work from Galway University Hospital in Ireland. So residual varicose veins after endovenous ablation in this era that we live in is a major problem because it represents to the patient the main bulk of the complaint. There are two schools of thought with regards to this part of the procedure. Some surgeons would prefer to do the phlebectomy at the same stage and get it over with, get it done in one setting, especially if they're giving the patient some sedation or some sort of anesthesia. The other school of thought prefers to leave it for some time and see what happens after 6 weeks, because probably what happens is that parts, if not most of these veins, regress and require no intervention. There are only probably 2 randomized controlled trials that I'm aware of comparing the early versus late avulsions after endovenous intervention. And I think it's worth doing more studies to look into this because the numbers are low and the evidence is not huge. Also, it represents a big question with regards to cost effectiveness and the extent of treatment for the patient, and also if we're doing unnecessary treatment for some patients, if that's the case with delayed phlebectomies compared to the early ones. So this study was a single-center randomized control study. It was obviously not possible to blind this either to the patient or to the interventionist. It was carried out in Galway University Hospital, and we aimed to recruit 200 patients and randomize them equally into 2 groups. The first one is intervention on the table at the time of doing the endovenous ablation, and the second group is obviously, if required, later on. We also categorized the groups into mechanochemical ablation and radiofrequency equally. So all patients went for this procedure under local anesthetic with tumescent injection, of course, for the radiofrequency, and no tumescence for the mechanochemical ablation. And avulsions were done using the avulsion hooks. Inclusion criteria, we included patients who are able to consent, above 18 years of age, and of course presenting with symptomatic primary varicose veins due to reflux in the saphenous vein, either long or short, and the varicosities had to be more than 3 millimeters in diameter and related to the refluxing vein. Patients were followed up for 12 months post-procedure with repeated quality of life assessment at 6 weeks, 6 and 12 months, and technical success appraisal at 6 months after the procedure. The patient filled the SF36 form and the Aberdeen varicose veins quality score also at these visits. At the 6 months follow-up, a duplex ultrasound scan was carried out to assess the technical success, and results were categorized according to the extent of occlusion of the vein to completely occluded, less than 5 centimeters, more than 5 centimeters, or predominantly open vein. So radiofrequency ablation was performed according to standard technique using the Cruiser Fast and tumescent injection, of course, and the MUCA was carried out with the Clarivane device. And the outcome measures were divided into primary endpoints of improvement in quality of life, of course disease-specific, using the 30F6 and the Aberdeen score to assess. The secondary endpoints were the technical success and the complications rate. So we managed to recruit nearly 200 patients, equally divided into the 2 groups. The main baseline Aberdeen varicose vein score was 22, decreased to 12 at 6 weeks, and then 11 at 6 months and 7 after 1 year. And this represented a very significant symptomatic improvement in both groups, representing about 65%. The mean change at 6 weeks and 6 months and 12 months was nearly 10, 11, and 11 and 13. This also was statistically significant. Both groups showed significant improvement in symptoms from baseline at all time points, and then there was significant difference in favor of early avulsions with a p-value of 0.024. There was significant difference in the need for further treatment between the delayed and the simultaneous group, of course in favor of the early group. And the odds ratio and relative risk of patients in the delayed group requiring further varicosity treatment were 27.8 nearly, and 18 for both groups. This also was very significant statistically. There was no difference between estimated number of multiple step avulsions required before and after the intervention in both groups, and there was no significant difference between the number of phlebectomies estimated as necessary before intervention in both groups. All procedures were completed as soon as possible if the patient required re-intervention or avulsions or so after the first 6 weeks of follow-up. So these are the results from comparing the Aberdeen score in the two groups, and that showed favor towards the early avulsion. And overall, the SF36 also showed similar trend with preference towards the early avulsion. Between treatment groups, there was a significant difference in quality of life at 6 weeks, and this significant difference did not persist over the follow-up period. In terms of technical success, at 6 months there was 95% technical success to truncal vein ablation on both groups, and 5% of the patients had areas of open varicosity. There was no significant difference in terms of technical success between the two groups, and we only had 4 cases of thrombophlebitis and no DVT, thank God. At least not recorded. And then we're still waiting for further analysis in terms of comparing the MUCA to the endovenous ablation. So in conclusion, ladies and gentlemen, we believe that leaving residual varicosities at the time of intervention is unfinished business, not just because of patient preference, but also with regards to improvement of quality of life of the patient, and in terms of avoiding unnecessary return to theater afterwards. Thank you.